Hi, my name is Alyssa Ashbaugh. I'm an MS4 at the University of California, Irvine, and I'll be presenting our poster entitled Psoriatic Disease in the U.S. Latino Population, Findings from a Comprehensive Review. Recent data has indicated that Latinos suffer from increased severity of psoriasis compared to white counterparts. Though the U.S. Latino population is growing at an increasingly rapid rate, little research has been dedicated to understanding the underlying mechanisms and patterns associated with these health disparities. We sought to conduct a comprehensive review of the literature to evaluate the current evidence on the presentation and treatment of psoriasis in Latino patients within the US. We found that psoriasis occurs in 1.6% of US Latinos compared to 3.7 and 2% of white and Black populations, respectively. Though Latinos have a lower prevalence of psoriasis, they do in fact suffer from increased severity. Additionally, they're more likely to present with pustular psoriasis compared to whites. Perhaps most importantly, the quality of life impact of psoriasis on Latino patients is much greater compared to whites, even when controlling for body surface area affected. Additionally, evidence shows that non-inferior or enhanced response to systemic treatments has been shown in Latino patients, suggesting that they may have an enhanced response to biologic therapy. We found that although Latino patients have a lower prevalence of psoriasis, they do in fact suffer from increased severity and an increased quality of life impact due to disease. In addition, they suffer from higher obesity rates, and further studies are necessary to elucidate relationships between other comorbidities and psoriasis in Latino patients specifically. We believe that barriers to care and lack of inclusion in clinical trials limits our understanding of psoriasis in Latino patients. However, with further research, education, awareness, and funding, clinicians may be able to better meet the healthcare demands of this medically underserved and overburdened psoriasis population. Thank you, and please reach out with any questions.
Hi everyone, my name is Mia Do. I am a MD PhD student at Cornell. Thank you for allowing me to discuss our finding on gender contribution to dermatologist salary in the Veteran Affairs or VA healthcare system. It is well accepted that the gender pay gap is persistent in many subspecialties of medicine, including in dermatology. But we also must recognize that a tremendous amount of effort has been made to combat this inequality in medicine over the past decades. So we think that it is important to revisit this topic, but instead of using a simplistic approach to assess whether inequality exists, we wanted to focus on additional factors that also contribute to the final salary and therefore can potentially confound the final conclusion of gender pay gap. Therefore, our study focused specifically on full-time equivalent base salary in VA dermatologists using publicly available data in 2018. We found that although there was an apparent difference in gender salary, this difference is attributed to academic achievement such as age index, years in graduation, and academic position, and no direct gender-based salary difference was found. While our finding doesn't eliminate the possibility that the difference in achievement may be a residual effect of a previously male-dominant field, it does show that base salary at the VA are currently gender neutral, given the same experience and expertise. Our findings are also in line with study focusing on physician salaries at the VA in other subspecialty. So together, these findings indicate that despite persistent gender pay gap in dermatology, progress has been made in some areas such as at the VA, but continued effort is needed to close the pay gap between male and female dermatologists in other settings. Thank you so much for listening, and please let me know if you have any questions.
Hi, my name is Claire Stewart, and I am a fourth year medical student at Weill Cornell Medicine. I will be presenting on the impact of onychomycosis and its treatment on patient reported quality of life outcome measures, a systematic review. This work was the result of a collaboration between Weill Cornell Medicine, and McMaster University. Onychomycosis is a nail fungal infection caused by dermatophytes, non-dermatophytes, and yeasts. It is the most common nail condition, comprising an estimated 50% of all nail disorders treated in the outpatient setting. Onychomycosis frequently leads to pain, discomfort, limited dexterity, and mobility, affecting daily life. However, the impact of this condition and its subsequent treatment on patients' quality of life has not been well studied. The objective of our study was to systematically review the available literature describing the impact of onychomycosis and its treatment on quality of life. 30 articles met inclusion criteria for our review. The most frequently used patient-reported outcome measure was the International Onychomycosis Specific Questionnaire. However, many studies used ad hoc, unvalidated questionnaires, limiting the ability to make comparisons across studies. Onychomycosis was associated with significantly worse quality of life compared to healthy controls. Patients reported embarrassment, stigmatization, and displeasure with their appearance, as well as impact on social relationships. Females reported worse quality of life than males, and those with fingernail involvement reported poorer quality of life than those with disease limited to the toenails. All treatments investigated were associated with improvement in quality of life, though there was a trend for oral treatments such as terbinafine and itraconazole to have a greater impact than topicals. In conclusion, the study finds that onychomycosis impacts quality of life, affirming that this condition warrants effective and prompt treatment. Future research should incorporate validated nail-specific outcome measures that accurately assess patients' cosmetic, physical, and social difficulties. Thank you.
Hello, I'm Dr. Janine Hopkins, board certified dermatologist in Monroe, Louisiana. It is both my honor and privilege to present at the Women's Dermatologic Society Parade of Roses the article that I submitted on the controlled application of platelet-rich plasma, stem cells, and other serums to wounded skin using my patent-pending applicator. So it's a true English proverb that necessity is the mother of invention. It was out of necessity that I realized it was dangerous to use needles and syringes to drip platelet-rich plasma over wounded skin. While performing such a procedure after a laser resurfacing treatment, I nearly experienced a needle stick. After removing the needle and using the open-ended syringe to continue applying the PRP to my patient's skin, I also realized that this gave us little control and there was risk of splatter. Also, by spreading the serum over the wounded skin with a gloved hand, I realized there was risk of contamination or even adulteration of the serum. So I began developing an idea for an applicator that could be easily attached to our syringes via a lure lock. The applicator is circular shaped and is perforated with micropores. Through the pores, the serum can seep onto the skin, and we can smear and rub it over the tissue without using our hands. This actually gives us more control, and it significantly decreases our risk of needle stick, splatter, or even contamination of the product. So I hope you'll find this information in my article very interesting and informative, and I look forward to your feedback and seeing how you think this could benefit you in your practices. Beyond our clinical practices of dermatology, it's also a great product that could be used in burn centers or even chronic wound treatments where we're having to treat open wounds. Beyond our medical practices, I hope to eventually have this available for people to use at home to put serums and creams on their children's eczema or impetigo or other such skin conditions that we chronically and frequently treat. So thank you. I appreciate your time and attention, and I hope you'll find this article very helpful. I look forward to your feedback.
Good evening. I am Dr. Musamud Sultana Akhtar, International E-Member of WDS from Bangladesh. My poster is on clinico-epidemiological profile of pemphigus vulgaris patient in a tertiary care hospital of Bangladesh. there is a scarcity of study on pemphigus in Bangladesh, so I become interested about it. This one is a cross-sectional study carried out in the Department of Dermatology and Venereology of Chittagong Medical College Hospital between the period September 2017 May and May 2019. Total 89 patients of pemphigus group were enlisted and diagnosed clinically and histopathologically and TIF. Among them, 85.4% patients were of pemphigus vulgaris, followed by 12.3% pemphigus foliaceus, pemphigus erythematosus 1.12%, and last paraneoplastic pemphigus is 1.12%. Here, female was 53.9% and male patient was 46.1%. And mean age of presentation was 43.5 years. This study reveals 93.25% pemphigus vulgaris patients were presented with oral mucosal ulceration. Last of all, I hope that this study will contribute to proper planning and establishment of blistering disorder friendly healthcare service. Thank you all for your patient hearing.
Hello, my name is Tiana Kazemi. I'm a second-year dermatology resident at the University of Minnesota, and I'll be presenting a case of improvement in a keloid associated with oral JAK inhibitor use on behalf of myself, Drs. Rhonda Farah and Maria Hordinsky. A 28-year-old female presented to our clinic for evaluation of a keloid on the chest due to acne scar excision 12 years prior. She had failed numerous treatments, including topical, injectable, and laser treatment. Past medical history was also notable for severe alopecia areata, for which she had been started on an oral JAK inhibitor, tofacitinib, 5 years ago with excellent response. Interestingly, our patient experienced landmark changes with significant decrease in erythema and thinning of her keloid during 2 periods. First, after initiation of tofacitinib, and second, after addition of serial interlesional Kenalog with 5-FU while still on tofacitinib. Of note, while she had intermittent interlesional Kenalog throughout the entire treatment course, this alone never resulted in appreciable improvement. Keloids are benign dermal fibroproliferative tumors due to aberrant wound healing with exuberant dermal fibroblast activity. Novel studies show that keloidal fibroblasts have increased receptor tyrosine kinase expression in comparison to fibroblasts in normal skin. One such increased expression is the IL-6 JAK-STAT3 pathway, which drives tumorigenesis. Inhibition of this pathway in vitro results in decreased cell proliferation, fibroblast migration, and collagen production. Tofacitinib is an oral tyrosine kinase inhibitor that targets the JAK1, 2, and 3 receptors. It is used in dermatology as an off-label treatment for refractory alopecia with promising results. In our patient, tofacitinib appears to have had a beneficial effect on a pre-existing keloid, likely due to suppression of the JAK-STAT3 pathway as discussed. To our knowledge, this is the first reported case of improvement in a keloid associated with oral JAK inhibitor use. While the cumulative effects of other treatments cannot be disregarded, the continued improvement during a 2-year treatment hiatus of the keloid and emerging understanding of the JAK-STAT3 pathway in keloidal pathophysiology offers an exciting insight into a potential new treatment. We urge providers prescribing JAK inhibitors to consider monitoring patients for any changes in incidental keloids. Thank you.
Hi, my name is Annika Kilnani, and I'm a second-year medical student at the George Washington University School of Medicine in Washington, D.C. This summer, I participated in a chart review that characterized the pediatric vulvar dermatology clinic at Children's National Hospital. Vulvar dermatology is a field in which both dermatologists and gynecologists may lack sufficient experience and comfort. Relatively few vulvar dermatology clinics exist in the US and likely help ameliorate that knowledge gap. Characterizing the diagnoses and misdiagnoses treated at Children's National Hospital in the vulvar dermatology clinic will help to provide insight into these knowledge gaps and the benefit of multidisciplinary clinics. It is also likely there are disparities in referrals to the vulvar dermatology clinic based on socioeconomic status and race. Comparing demographic data of patients seen in vulvar dermatology clinic compared to general dermatology clinic may provide insight into the disparities to access to care. In addition, there may be ethnic and racial factors for vulvar dermatologic diseases that have not yet been described. This multi-ethnic, multi-patient, racial patient population seen in this clinic will provide early insight into these unanswered questions. In the future, we hope to look more carefully at the two most common diagnoses seen in the clinic, lichen sclerosus and vitiligo, which are both frequently misdiagnosed at the primary care level. Thank you for listening.
Hello, everyone. My name is Alexis Carrington. I'm a postdoctoral research fellow at the University of California, Davis, and I'm honored to present a case of squamous cell carcinoma of unknown primary identified in an inguinal lymph node at WDS's Parade of Roses. So jumping right into it, we have a 60-year-old Hispanic male presenting with a painful left inguinal mass, persistently enlarging during his first hospital admission 4 months ago. His prior treatment included doxycycline for 3 weeks, and a CT scan of the abdomen and pelvis revealed a prominent left inguinal lymph node measuring at 4.59 by 3.64 centimeters with an apparent central necrosis. However, he was lost to follow-up for IR-guided biopsy. His review of systems was positive for scrotal edema, weight loss, and night chills for the past 5 months, otherwise unremarkable. His medical history was hypertension, type 2 diabetes mellitus, and benign prostatic hyperplasia. His past surgical history was negative, as well as any family history of similar skin problems or skin cancer, and his allergies were also negative. So at presentation, there was a large erythematous firm to hard inguinal lymph node and indurated nodule on the left inguinal fold with overlying erosions and few satellite erythematous papules. However, the exam was unrevealing for primary cutaneous squamous cell carcinoma. An IR biopsy was done at this hospitalization, revealing metastatic squamous cell carcinoma in the mass. A repeat CT abdomen and pelvis revealed an 11.2 by 7.4 centimeter left heterogeneous inguinal mass, along with multiple enlarged lymph nodes and masses. Immunohistochemical analysis revealed no loss of nuclear expression of DNA mismatch repair proteins and a low probability of macrosatellite instability. A whole body PET scan showed metabolically active mass in the left groin and additional nodules and nodes along the left distal external iliac nodal station, consistent with what was seen on CT abdomen and pelvis. Interestingly, his workup for a primary source was negative, such as CT scan of the chest, endoscopy, and laryngoscopy all were unremarkable. Only pertinent positive is he had thickening of the posterior bladder wall, but it was associated with likely bladder obstruction from his BPH. So he was diagnosed with cancer of unknown primary and was given weekly Taxol carboplatin combination, which was completed, and no surgical intervention was deemed at the time by surgery. At 3-week follow-up, he was started on gemcitabine and cisplatin, and the primary remains unknown. Cancer of unknown primaries are approximately 3 to 5% of invasive cancers and 2 to 3% of all epithelial malignancies, the vast majority of which are adenocarcinomas and undifferentiated carcinomas. Typically, diagnostic imaging and molecular techniques are done for the workup of CUPS, but as we've seen, could be unyielding. CUPS are associated with poor survival and is identified as the 4th most common cause of cancer deaths. Thank you very much for listening to my presentation.